I'm going to get into some practicalities before we talk about the substance, because we all get worried about those, don't we? If you've got any questions, there's a chat bar on the right side of your screen. It usually has 3 little dots and you can click on chat. If you've got any questions, put them in that bar and they'll be picked up. We've got somebody who's picking them up. And we'll refer to them at the end of the session. Okay. If you find that you're knocked out of the conversation by accident, please email my colleague Rebecca, and her address is up there, Rebecca at Healthwatch Brighton and Hove. So if you've got any techie in issues, Rebecca's the main person. Just to say that we are recording this in the main room. We're going to have some breakout sessions after a little while, and those will be private. But if there's anything that's said in this main room is going to be recorded. I think I need to remind you to turn off your cameras and on your mic at the moment, will you? When we get into the breakout rooms, we've got some sensitive issues here. If you can, raise your hand, either metaphorically with the little hand we have on Zoom, or your real hand. And the facilitator will make sure that you get a chance to say what you want. And if you on the chat, if you actually put who you are, it'd be quite useful. We know, as I say, there's some sensitive issues here, and if you feel as if you need to have a bit of private space, by all means drop out of the meeting and come back in. But we have actually got some people who are willing during the meeting, the main meeting, or afterwards to talk to you. And they're Dr. Declan Corley, Sarah Gale, and the Reverend Johanna Elliott. And what you would need to do is, when you're in the chat, scroll down to their name and click on them and have a private conversation. Make sure it's a private conversation. And if that's difficult, send an email to us and we'll sort out a possibility afterwards. So I hope that's the most of the sort of boring stuff we have to start off with. Okay, by way of introduction, as I said, I'm the chair of Healthwatch Brighton and Hove. I initiated the study, which led to a report that we did last year, A Good Send-Off, Patients and Families' Experience of End-of-Life Care. My colleague and co-writer, Christine de Cruz, is going to talk about that in a few minutes. I've worked for over 50 years in health and social care, and I'm specialised in older people's care. And on the personal level, I've had a lot of experience of death in my family, starting with my mother dying of cancer when I was 15. So I'm very eager that more attention.
Do you find that Phil spends a fortune on whimsical wine?
No,
excuse me, we've got can everybody turn off their mics, please? Because I can hear some personal conversations going on. I'm not worried, but some of you might be worried later on. Okay, sorry about that. So as I say, I've got a lot of experience of personal and professional experience of dealing with death, and want to make sure that people's end-of-life experience is as good as they can be. This time last week, exactly this time last week, I was at the funeral of a good friend who died of cancer, and it was very sudden. And a close family member shared with me that one of the most difficult things that she found was coming to terms so quickly with the impending death. But, you know, trying to work out where that would best be for everyone, the person who was dying and the family members, and all the practicalities of the arrangements. It was one of the most stressful period of her life. And I just feel as if, imagine how awful it would be if no thought had been put into that, what might happen in the future, and no plans put in place. As you know, when people are asked, most people say they would like to die at home, but in fact, most people don't. and this is what Healthwatch found when we talked to patients and families just before the COVID outbreak. It was just over a year ago. So we wondered what could be done to help people achieve this wish and get what they wanted towards the end of their life. And that's what this workshop aims to do. Now, the breakout issues, we want to get somewhere with this discussion. A lot of the issues I intimated, you know, I was 15 when my mum died, which is over 50 years ago, nearly 60. And a lot of the issues are still very similar. So we want to actually sort of push things on. And so you can talk about what you like, but we'd like you to particularly address certain issues, which I will come back to you, so that we can take questions to the clinical commissioning group. Those are the people who decide on, you know, what sort of services are going to be available across the piece. And we've got some nurse consultants who are going to listen to what is going to be said at the end. So today is going to help us think and plan, whether we're ordinary people, people who are family members, whether we work with people at the end of life, or all of those things, to try and get some practical suggestions towards the end of the meeting. So if I ask you again, I'm getting some feedback. Please turn your mics off if you can, if you remember, so that everybody can hear. I'd like to now introduce Dr. Marion. I've lost my lost my bit of paper.
Frances,
okay.
While you're looking, are you aware that you asked us all to turn our cameras off as well? And that might not be what...
Okay. Can you turn cameras off? So that means that if everybody's that we can't, we could just see the person who's speaking. Is that okay? Dr. Marion Messiah, who's actually a roving GP, and she's got a special interest in end of life care, particularly for older people. She'll tell you probably a little bit about what she does. So Marion, it's your space to talk about this issue.
Hi everyone. Can you hear me okay? Yeah, great to see so many people here. I was reflecting on what would be most useful to share in just a few minutes. And I think I have two key messages. And the first is that although thinking and talking about death can be difficult and scary, and we have a tendency to put it off, by engaging in these conversations, we have the best chance of giving our patients, our loved ones, ourselves, the best chance of having the care that we want at the end of our lives, and ultimately the deaths that we want. So it's important stuff. A big part of my work and my passion is to help frail elderly people and those with chronic conditions avoid the revolving door of repeat hospital admissions towards the end of life, which is unfortunately what the data shows. And again, it came up in the Healthwatch report, which we'll hear about later. And my own experience and research shows very clearly that the more we plan, the greater the likelihood of achieving the desired outcome. Essentially, the more we prepare for death, the less stressful the experience of death can be. Can I have the next slide, please? Next slide, great. So what I wanted to highlight in this slide is it's not advanced. For many years, I accidentally added the D until the Simone Ali, the director of the hospice, corrected me. It's advanced, and I think that's key. So the process can be started at any time, but really the earlier the better, when people are able to communicate what matters to them. Before, for example, the dementia becomes advanced and people may lose mental capacity to become involved in the conversation. And before an emergency situation arises where somebody is seriously unwell with an infection, for example, they might be drowsy, they might be confused, too sick to have the conversation. And the other thing I want to highlight in this slide is that the words values, goals and preferences are repeated twice. And essentially, that's the start of the process, exploring what our values, goals and processes are. Have the next slide, please. So I've said it's not advanced. So how do we start the conversation? And essentially, it's these 4 questions, which aren't very fancy questions. They're quite straightforward. The first one is, what's important to you, to your patient? Ask them what matters. What do they value? The next thing is, what do you want to happen in the future? So essentially, that's about wishes for future care. And what do you not want to happen in the future? So that's exploring what we're scared of, what we're fearful of, what we want to avoid. And then the last question, who do you want to speak for you if you can't speak for yourself? Whether that's a family member, a relative, a neighbour or someone else. Can just have the last slide, please. So just a few words about respect. This is version 3. Many of you will be familiar with this and be using it. Hopefully we'll start seeing more and more of these as it rolled out across the country. It stands for Recommended Summary Plan for Emergency Care and Treatment. And essentially it's a type of an advanced care plan that's relevant for an emergency situation. I mainly want to focus on sections 3 and 4, but just before that, I just want to highlight the word shared under number 2, shared understanding of my health and current condition. Essentially, this form is a documentation of a conversation or a series of conversations between a person and a clinician. And that clinician is generally a GP or a senior nurse. It might be a hospital doctor. But really anyone can start having these conversations, and much of the information that's included on these forms will be covered by asking those 4 questions. So the use of the word shared understanding, there's often a mismatch between what the clinician thinks the person's health and condition means and what the person understands. So that's really an opportunity to talk about things like prognosis, because often people aren't aware, for example, that they have a terminal life-limiting condition that will end their lives. And then moving on to section 3. For those who live with serious life-threatening illness or who are gradually deteriorating from a common condition such as dementia or lung or heart disease, there needs to be a discussion exploring priorities. And on one side, we have living as long as possible. And on the other side, we have quality of life and comfort that matters most. And the boxes below, what I most value and what I most fear and wish to avoid, are a way of exploring where we might be on that line. For most of us here, I imagine we're going to be on the left-hand side, but there will be some people who are clearly nearing the end of their lives that will be on the right-hand side. And I just want to give a bit of an example here. At the height of the COVID pandemic, I had a patient with chronic respiratory illness who was becoming more breathless, and we both suspected that they were brewing an infection, and they'd had lots of admissions to hospital with exacerbations, with infections, and they'd had oxygen and intravenous antibiotics and come back home. But they knew that each time they went into hospital could be the last time. And when we completed this form together, what became apparent was what they most valued was being with their family, and what they most feared was dying without their family around them. And at that time, a hospital was limiting visitors. And so they told me they wouldn't want to go into hospital. And so we filled out section 4 to say that they would take oral antibiotics at home, but that they wouldn't want to go to hospital. And they had oral antibiotics. I prescribed medication to help with the sensation of breathlessness and anxiety. But unfortunately, they did die, but they did die surrounded by loved ones. In version 2, there wasn't actually the option of this middle box of balance, extending life with comfort and valued outcomes. And I think it's important that we realise that for many people, it's not a binary, extending life or prioritising comfort, but there is going to be this discussion. And many people, for example, will say that they will go to hospital if there's a good chance of returning to what we call baseline function or their condition as it is. In that box, there's also an opportunity to document things that would go against what the patient or the person would want. For example, it can take a young person many, many months to get over an admission to intensive care. And a person may have reached a point in their life or in their illness where on balance, they're unlikely to benefit from an admission to intensive care or resuscitation attempts. So in that box, you could put accept hospital admission if there was a chance of returning to baseline function, but they wouldn't want to go to high dependency unit or be ventilated or go to intensive care, for example. And I think I also need to just say that the CPR, it's not an effective treatment for people who are approaching the end of their lives. And I hope that in time, this form replaces the red bordered do not resuscitate form, because it does contain a lot more information than just that decision around CPR, which is what the red bordered form relates to. So that's before I end, there's just 2 key messages really. If we want to achieve our preferred goals at the end of our lives, at the end of our patients' and lives, we have to engage in these conversations early and stop avoiding the difficult conversations. And the second point, it's not advanced. We can all start asking the questions, what matters to us, what's important to us, what do we want to happen in future, what don't we want to happen, and who would we want to speak for us if we couldn't speak for ourselves. Thank you.
Thank you, Marion. You raised so many issues there that are really important, and I can see that people will be sort of talking about that quite a lot. So as a way, we will have chance in the chat room to sort of explore some of those issues a bit more. Can I move on and invite the next speaker, who's Lee Mills, to join us? And Lee's got a very interesting role. She's an end-of-life companion and a funeral celebrant, and I think she's going to tell us a little bit about what those roles mean. Thank you, Lee.
Yeah, I'm Lee. I'm principally a musician, or at least I am in non-COVID times. I run choirs in Brighton, and about 3.5 years ago, I learned about the role of end-of-life doulas. If you're not sure about what that is, don't worry, I'll explain in a minute. I did my training with the Lewis-based foundation, Living Well, Dying Well, and I'm now part of an UK-wide network called End of Life Doula UK. Some of our referrals are just made by word of mouth, but a lot of the referrals come through End of Life Doula UK. I've also recently become a funeral celebrant, mainly just as an organic part of my work, going through end of life with various clients who then wanted me to organise and be the celebrant for their funerals. And I've just been taken on by Arca Funerals in Brighton, so that's a new departure for me. So the term end-of-life doula, which I have to admit I'm not massively keen on, but it's one that we've been stuck with, so we have to use that, is often met with blank faces. But if I describe myself as an end-of-life companion, I think you'd probably have more of an immediate handle on what that might mean. We walk alongside those with terminal illness, providing emotional, spiritual, if it's wanted, and practical support, filling in any gaps between any of the other professional services that people might be engaged in. And we also support people's friends and families, which I think is a really important part of the role as well. We might meet with people from the time of diagnosis, or sometimes we're called in right at the end of life in the last few weeks, months, even hours of life if assistance is needed. We meet people and work with them in care homes, hospitals, hospices, or at least we did before the pandemic struck. That's curtailed quite a lot of face-to-face activity for some doulas. And we also obviously work with people in a home setting, particularly where people want to die at home. During the pandemic, I've continued visiting people in home settings, but in a lot of other public buildings, visits sadly have been stopped and confined to videos. Some doulas work in a voluntary capacity, particularly if they're in training. They're always glad of the experience, and other people charge for their services. I tend to do a mixture of the two. So I generally charge people who can afford to pay for me to come in and help, because it is part of my job. But that also enables me to work with voluntary organisations, and I've been able to work with homeless people in homeless shelters sometimes. And whether you're paying or not, you always end up doing a lot more than you're paid to do. When we're not actually working with people right at the end of life, other things that we're involved in include working on people's advance plans that Marian's just talked about. There are some really organised people out there, I'm glad to say, who've started thinking about that way before they're even ill. And that's something that we're very keen to encourage to people to do, which Marian was talking about herself. We run death cafes, some of us. That's something that I really enjoy doing, which is just an open forum, usually over tea and, very importantly, cake, getting people just breaking down the taboos about talking around death and dying. They're not bereavement support groups, but just rather a forum where people can explore any issue about death and dying in a safe space. And we're really just involved in a lot of death activism, trying to sort of demedicalise death, working alongside health professionals. There are lots of different types of personalities in the doula world, and depending on what you want, you might be into the sort of whole new age thing and want singing bowls around your deathbed. I tend to be a bit more down to earth and irreverent in my approach, and that therefore means I work with similar types of personalities. How does it work in practice? Because if you've not heard of a death doula before, that might mean nothing to you at all. We help people with housework sometimes, helping around the home, providing advocacy with medical services, and sometimes accompanying people to appointments as well. There's loads of things that we do, and probably because I know we're a bit pushed for time, the easiest way for me to describe what we do is to talk about one of the last people that I've just worked with. I'm currently working with 3 very different personalities with very different situations. But just recently, I worked with a client who died about a month ago. And what started off as a sort of telephone support over the first lockdown, or sorry, not the first lockdown, I met her in about November. She wanted emotional support with the knowledge that she was going to not live for very much longer. But when the latest lockdown occurred, her needs changed very rapidly. And one of the things about being a doula is just providing that consistent and flexible support. So she was a young mum with 2 school-age children. And when lockdown hit, all of her support networks, apart from the amazing Hospice at Home team, which came from St Barnabas Hospice in Worthing, everything else fell away. And she asked me to come in at least 3 times a week. That particular role ticked every job in the job description box that a doula could do, and some actually. A lot of it involved listening to her fears about dying and making peace with what was going to happen, making sure that she actually knew what was going to happen to her, because I think that's something that's often overlooked. People are so afraid to talk about what death looks like, but it can be enormously comforting, really, to know what that end of life might look like. We drew up her end of life plans, and I facilitated quite a lot of difficult conversations between her and her husband, who was less keen about talking about death in as open a way as she was. So at this time, her children were being homeschooled, and my previous primary school teaching came back to me, where I had to sit at the table and do long division, which is not something I ever thought I'd be doing as a doula, and also teaching the children trampolining tricks. I would spend time providing massage. I'm not a massage expert by any stretch of the imagination, but most of us find some sort of human touch comforting, and that was something that definitely worked for her. I would help with the laundry. With a busy family, there's a lot of that going on. She also wanted me to support her friends, and a lot of those were across the world. She came from the other side of the world, and it was very difficult for her friends not to be in contact with her. So I had lots of Zoom calls with tearful Australian friends who wanted more information that she was sometimes too tired or too emotionally distraught to provide. I was with her. I was fortunate to be with her right at the end of life, which is something that she'd requested. And actually that worked really well, to be there with her husband, with the children playing in the room next door, and the hospice team just happened to be in at that moment. So it was very much a sort of team effort. And she had exactly the death that she had planned. She'd asked me to lay her out, and that's something that doulas can get involved in as well. She'd also written her funeral plans and asked me to be the celebrant for her funeral. So part of my role extended beyond her death, supporting the family, and together we came up with a funeral service that we felt reflected her and involved the children as well. Gradually, the role has receded, as you might expect, after a month or so after death. We occasionally check in to see how everybody's doing. And I'm still sometimes getting phone calls from grieving relatives and friends who need a bit of support. I think the things I'd like to get across today is that I'd really like to see the doula role extended out into the community. I'd love to see more provision for end-of-life care for homeless people to be accessing doulas in the community. Some of this, I think, is going to involve accessing grants and funding within different organisations. I'd also really like to see a sitting service set up in hospitals so that nobody has to die in hospital alone. We know that services in the NHS are so stretched at the moment. It would be great to think that there were people on the other end of a phone who could be called up at a moment's notice to come and sit vigil with people so that they can have somebody with them as a constant presence. I'd be very happy to set up a pilot for that if anybody's interested. And really just see the whole conversation about death and dying opened up in the community so that people can get the death that they hope for. Thank you.
Oh, thank you, Lee. I mean, that was a very emotional presentation, and I can see from the chat that lots of people are interested, and I think you're going to provoke quite a lot of conversation there about the sort of the non-medical, if you like, side of death and dying. So thank you very much. And I feel as if I should give you more time, but we haven't got it at the moment. So I'm going to pass over to Christine de Cruz. And Christine is a director of Health Watch, but she and I did the work, the actual field work, if you like, on our report, A Good Send Off, and she's going to tell you a little bit about it. So over to Christine. Thank you.
Thank you. Good afternoon, everybody. The report, A Good Send Off, Patients and Families' Experiences of End-of-Life Care, was based upon a pilot study of 15 people. All of the patients had an end-of-life prognosis and were in the last days or weeks of their lives. We conducted interviews before they were discharged from the oncology ward of the Royal Sussex County Hospital, and then again at home, and in some cases in hospital again and home again. We conducted this study between November 2019 and January 2020, pre-COVID-19. All of the patients have now passed away, but are survived by their families and friends who were affected by the end-of-life care process. We made 10 recommendations that were accepted in full by the NHS, with a pledge to improve care pathways, correct elements of personal insensitivity, and most importantly, absence of coordinated planning. Let me highlight a few of our findings. We found that people experienced enormous churn during the last few days and week of their life, often being admitted in and out of hospital. Care and support at home was of variable quality, with resources not always in place to support them. There were several instances of failed discharges, with people going back into hospital very soon after their discharge. Follow-ups of community health services appeared to families to be hit and miss. GPs were invariably not involved after discharge with the patients we interviewed. Many families felt they were not appropriately involved, even though they were likely to be the main carers when the person was discharged. No one had heard of respect or remembered early conversations about planning the end of their life or death, even though staff said discussions had taken place. People who had been discharged through the specialist palliative care team at the hospital or were linked into Martlet's hospice fared better, with their care plan being coordinated by specialists. To put a human face to my points, I'd like to tell you about a patient story. The patient was an 80-year-old man with prostate cancer. The day before he came into hospital, he was rambling across the downs, and now he was interviewing him, paralyzed from the waist downwards, and getting ready with his son beside him to be discharged. I managed to speak to him by phone a few days later, and he was in hospital again. We talked about this last visit to A&E and what had happened. He said the carers noticed he had blood in his urine, and they organized for an ambulance to take him to A&E. The carers did not wait, but called his sons. They waited for about 2 hours for an ambulance. The patient was assessed in Royal Sussex A&E, and they recommended that he be taken to Princess Royal Hospital, as this is the specialist unit for urology. Although he was put in a side waiting room, it took 9 hours, including being transported from Brighton to Haywards Heath, before he was set up in a ward. It was most difficult for him to wait in a chair for so many hours. He talked about discomfort, distress, and pain. He said, once in a ward, everything was fine. People are so overworked in A&E, just rushing around. He scored the service with a 3, saying, mainly because of all the hanging around in A&E. The rest of the service and treatment in hospital is excellent. He passed away a few days later. Almost a year later, I spoke to his sons about the report, and they told me how upset they still were over this particular episode in A&E and in hospital. My closing plea today is to ask that we prioritize transforming service delivery from a patient's perspective and not confusing it with integrating organizational change. Thank you.
Thank you, Christine. Again, another very emotional example of somebody who didn't really have the best end-of-life care, and a good challenge to everybody here. Right, I think, are we all back in the big room now? I'm subject to technology. I have to do what I'm told. So I think we're all back in the big room. So I think it would be helpful if people turned off their cameras unless they were you know, going to be speaking, etc. Because otherwise it's quite difficult to work out what's going on. And mute. But if you're a speaker or you're speaking, then obviously put your camera, etc. on. I'm going to go around the facilitators and ask them to do some feedback, and then we're going to have some remarks from Sarah Pearce, who's from the clinical commissioning group, who's going to say something about these issues. So, okay, so first of all, can I ask Marion Messiah to feedback 3 main things that came out of your group?
Yeah, it's difficult, isn't it, to,
yes.
to summarize it all. There's some big themes that came out. The first one, I think, is about the patient feeling like they have some control, that they feel listened to. We were talking about individualized care a lot, putting the person at the center of that care, really asking them what they wanted. The second thing that came out was compassion, kindness, empathy from the people that looked after them. It's a very vulnerable time of life, of course it is. And, you know, you can pick up on these things, can't you? And I think that's very important. And the third thing, actually, it came from a discussion about preferred place of death. And we talked about quality of care. So ensuring that you get quality of care, whether that's in hospital or whether that's at home, that there might not be a right or a wrong place to die, but it was about the care that was being assured of, that care that was important. Thanks.
Okay, well, you did very well, Marion. I'm not sure I'm going to be as good as you myself, but thank you. Okay, Christine, would you like to feedback? Are you there, Christine de Cruz?
Yes, I am. Hello. Well, we had a lot of commonalities in how people felt about what they would like, what their 3 things were. Everybody said that their choice would be to die at home. They wanted to die at home, stay in their own home, not be transported to hospital. The second thing that many of them said was that they would like adequate medication to control their symptoms. That came up quite frequently. And people really wanted their families close by. And then there was some discussion about, at the very end, whether they wanted the family to be present or not present, but wanted them nearby and wanted that choice. But again, very firmly in the home and having the right medication around them. Some people in the days leading up to their death would like to have glasses of champagne, reminisce about wonderful things that had happened in the past. We then also had something that I thought was quite interesting, which a lady called Di mentioned, and that was the difference between having mental and physical issues at the end of life. And she articulated that quite well. So when we come to question time, I've asked her to make a couple of comments on that. We also talked a little bit about some of the DNR and some of the things that had happened which people were concerned about, and that is no involvement and poor communications. That was a concern, no involvement in DNRs and family members signing off on DNRs, but the actual person involved not knowing about that, and how concerning that was. So communications came out as another major theme, so that people knew where they stood and everybody was aware of what was happening. So those were the main points. Thank you.
Oops. Thank you, Christine. That was very interesting. Let's see what Lee's got to say. Lee, are you there? Yeah, you are.
Yeah, not surprisingly, there'll be quite a lot of crossovers because the same themes seem to be coming up again and again. The first one that kept coming up really was this whole idea of dignity, having a dignified death. And when we expanded on that theme to work out what that meant for different people, a lot of that was about respect, being treated with respect and not having any of your wishes overridden. It was also linked in some ways, actually, dignity to not being in pain or distress, so that you can have a dignified end to your life. The second thing was about advocacy, having the chance to be listened to, and how that would give you some control about how your life ended. We all agreed that advanced planning was the way to go for that, really. People were quite interested who hadn't thought about it before to know that you could be so specific with advanced statement of wishes, talking about having glasses of champagne and things like that. But the main thing about the advanced planning was being treated as an individual and realizing that we all want different things. Who we were with at the end of life is again something that's been mentioned before, but that was quite important, and the importance of touch and being spoken to at the end of life. As we've often told, hearing is the last sense to go when we die. People are keen that people are talking to them at the end of life. And the last bit actually that came up that's maybe not been mentioned so much is about honesty and transparency about what's happening to people. We've all come across people that don't want to be told exactly what's going on, but most of the people in our group felt that they wanted really honest conversations about what was happening to them at the end of life. They didn't want to be spared the details. They actually wanted a proper picture of what was going on with their diagnosis and when their life was likely to end. I think that's probably a roundup.
Okay. Okay. Thank you very much, Lee. Some themes coming out of the various feedback, which is not surprising, really. Okay, we'll go to Bobby. Bobby, we haven't introduced Bobby before. Bobby Farsidis, Professor Bobby Farsidis, who's works at the university around end-of-life care. Bobby, are you there? Bobby, yeah.
There, yes, thank you. I'd just like to thank my group because they brought a wonderful combination of professional and personal experience into the discussion and blurred the boundaries between it and reminded us that, you know, this is something we've all got to be thinking about. Some very similar themes. A wish not to die in pain, to have good symptom control, to see it, a term that was borrowed from your own report, to see death and dying as a dignified process, not an event, and to pay attention to that process. A very strong message came out that really, to get it right, care does need to be personalised, and you need to think carefully how you're going to do that, because people were wary of what might become tick box exercises and form filling exercises, when what they really wanted was something that dug down and find out the things that were genuinely important to them. And we had such a lovely variety of things: having your pets close by, being close to nature, having music, getting the football results if it was a Saturday, whatever else was going on. And it just sort of showed that we have to find ways of accessing, storing and using that data. But the most original thing that came out, and this wasn't just one person, this was several people not only wanted to plan for their own death and dying, they wanted to leave legacy plans. They wanted to feel that they had said things that would be listened to and become important in terms of thinking about how children might be looked after their death, or what people would do around the funeral arrangements. And one person in particular drew our attention to the importance of respecting people's spiritual beliefs and understandings, and translating that where possible into being able to offer them the ceremonies and rituals that would be meaningful. So very similar themes, but I was very struck by this fact that the planning doesn't stop at the moment of death, it goes beyond.
Okay. Okay. Thank you very much. And it is interesting, the from whatever perspective people are in, whether they work in the area or they're ordinary people, let's put it that way, with mass observation has got a day, hasn't it, today on ordinary people. Nobody's ordinary, we're all extraordinary, I think, in this particular area of interest. Okay, Michelle, are you there? Yes, Michelle Kay. Hi.
Hi. Yes, we had a lovely group actually, and thank everyone for being very honest and giving some reflections about from their own experience, but also from working with people at the end of their life. And the three kind of key things that came out from our group was firstly around control, being in control of the situation and governing your own journey, but also the reality check that while you can lay the plans out in advance, that sometimes the situation ends up being quite different. So you can plan to be living at home, as people have mentioned before, but actually it would be better for the patient and for the family around them that are unable actually in reality to support that person, for the patient to be somewhere else. The second thing was honesty from those around you, and it was the hope versus the honesty. Again, having experienced this myself with my own family, you can hope for the best, but you need to prepare for the worst. And it really is trying to get that balance where people really don't want to talk to you about the fact that you might not be around for too much longer, but actually the keenness sometimes of the patient themselves to ensure that they talk to their family about how things will be once they've gone. And with that certainly brings me on to our third point, which was relationships, all about relationships with yourself and with your loved ones. So somebody in our group mentioned the really important thing of being honest first with yourself. How do you want your journey to be towards the end of your life? And then then having that relationship with those who are close to you to express those wishes.
Thank you, Michelle. Again, a sort of a number of things that resonate, I think, with all of the feedback. We had a few slightly different things as well. I think we started off by talking about cultural issues, about having openness, about talking in advance about death and dying, because in some other cultures, this was death and dying was part of life, whereas it seems to be sort of like more of a taboo subject within some parts of the British culture anyway. And so there was an issue about sort of like trying to supporting, I suppose, the conversations in advanced care planning and thinking about the issues in the respect document. A big support for the respect approach. It is only a document, and it should be an approach, and that should be just the way in which wishes are recorded. And we had somebody from the ambulance service who said it actually really made a difference in terms of people's wishes being able to be respected at the end of their life, if people had got some sort of advanced planning, because it was known then what they wanted at the end of their life. That resonates with what Christine said about not wanting to go into hospital unless you really need to. There was quite a big discussion about, I suppose, diversity and differences, and I think the other side of that is personalisation. That some groups of people, the system may not be set up really to respect their needs, particularly the LGBTQ community, some religious communities, and then we had a conversation about people who hadn't got the mental capacity to maybe to consent to some of these this planning, or what happened to them towards the end of their life. Those people with dementia, and particularly people with learning disabilities, to be able to particularly be aware they may not be able to speak up at the end of their life. So we tended to look a bit objectively towards other people who were not in a position to speak up. Concerns about people who were alone, particularly in residential care homes at the end of their life, and some advice, some help. There's plenty of advice around on the practicalities, but it's around the compassion. There was a feeling that when people died, and it goes back to the openness and the cultural issues about not talking about death, that people need to be remembered and be able to be discussion take place about them when they've actually died. Support when they're an ability to support those people when they're alive, particularly if they haven't got any family, and to be able to keep talking about them when they've gone, particularly in care settings. And that brought us to our last point about that staff need support if they are going to be putting in a very compassionate approach with good communications, with that's very personalised. This is quite hard on them, and they see death a lot, and so there's a need for support for staff to be able to go on caring and looking after their own care needs as well in relation to end-of-life care. So I'm not quite sure whether we came out with 3 points, but we did have a number of issues that we felt needed addressing in the end-of-life conversation. Okay, well, have I got everybody fed back now? I think I have, haven't I? Before I started this session, I quite blithely said I'd try and sum up about what had come out of the webinars, the discussion sessions, and I think it's quite difficult. But I think the 2 or 3 things that come over to me is that people want to be treated as individuals, and they want control over what's going on at the end of their life. And that may be very different for different people. And they want some choices and options. And a lot of the things they want don't come up on the, they're not medical. They're to do with people as people and people in their relationships. And so I think it seems to me that irrespective of where people die and what the situation is when they die, it's their life needs that they need to have addressed at the end of their life, which as long as they've got good pain control and they're getting care and support from the right professionals coming in, it's that's the area that we might need to concentrate on. But I'm now going to invite Sarah Pearce. Are you there, Sarah? Is Sarah there?
I am.
Okay.
Sorry.
Okay, it's all right. Okay, I'm going to invite Sarah Pearce, and Sarah Pearce has got some responsibilities around end-of-life care with the Clinical Commissioning Group. For a lot of you here will know what the Clinical Commissioning Group is across Sussex, but it's the people who, I suppose, set the strategy and the policies and look at the resources available. But she's had a lot of experience in this area and is very committed to this area. And I was going to give her a few minutes to say what's going on. Can you hear me?
I can.
Yeah.
Thank you,
hear me. And any reflections on what's actually been said, Sarah?
Thanks, Fran. And I'd just like to start by saying thank you to the Health Watch team, and also to the groups across Sussex who worked really hard on providing a really wide and varied list of events over this Dying Matters week. It's really been a real privilege to be part of being here today, and also some of those wider events going on elsewhere. I guess my reflections, Fran, would be, it's just brought home in sharp focus to me about how important it is to ensure that the views and thoughts and ideas that have emerged and been discussed today are clearly put front and central as we think about services for the future. And people talked quite a lot about making those services the right sort of services. They're not about events, And you've just picked up a very important point about a lot of the time when we talk about commissioning services, it is about the practicalities, but we also need to think about the holistic elements that sit around those as well. So I think this is a really timely reminder of how we make sure that we keep that, the wishes and choices and preferences of people really central to any developments that we're making over the next few months and years. I suppose really just to say on the matter of respect has been one of the very key areas of development for all of the Sussex CCGs, and is something that we're highly promoting in terms of embedding it. I don't think it's about replacing old version 2s. I think it's about getting those conversations going and making sure that people's wishes, choices and preferences are being discussed as part of that process of conversations, and those are being recorded and updated should choices and wishes change over time. In the not too distant future, we've been working on quite a wide suite of communications to be used across the area, so we will definitely be using all of our connections to make sure that those resources are available. They're available in not only different languages, they're available for those in videos and lots of different formats to make sure that they're as accessible as possible. And what we've really tried to do through those communications is to really underpin what those respect forms are there to do, what the process is, how people's conversations can be taken in account and made sure that those plans are shared across the system. So should people be in a situation where they can't express their needs at the time, that those are well recorded and can be followed. From a point of view of end-of-life care, we really welcomed obviously all the recommendations from the Health Watch report. We know that across Sussex there's quite a number of different really good areas of end-of-life care, but there are also areas that we really need to think about how we could develop. And that's going to be the focus of our plans over the next few months as we come out of our experience of COVID-19 and think about what we need to be doing for the future. I think underpinning that is the work that we're doing with our public health colleagues both and ensuring that that sort of community-based approach is also there as part and parcel of that. And finally, I just wanted to mention the real role of education and training, and that's something again that we've got some real good pockets of that education and training available across Sussex, but we would really want to be strengthening that over time and making that accessible not only to professionals across the board, but also to patients' families, so we can hear about experiences and really tying into that idea of conversations, deaf cafes, more community type approaches as well. So thank you for the opportunity, and it's really been great to be part of the event. Back to you, Fran.
Yeah, thank you, Sarah. I just wondered whether or not we've got a couple of specialist nurses here, Lisa O'Hara and Sue Line, whether they wanted to just say anything or wanted to, or are they embarrassed about being picked on? Are you there?
Yes, I'm here.
Okay.
Hi, it's Lisa.
Yeah. Okay, thank you for joining us. I just wondered whether or not there's just any quick observations that you might want to make. And
there's Sue as well. Great.
You've got support. Okay. Yeah. Okay. Is there anything you wanted to say that came up in the conversations that you'd like or you would like to add?
I think it's really great to meet everyone in the group and listen to everyone's different perspectives. I think the only thing that didn't come up was as one of the three things that are most important, but I think it would be most important to a lot of people, is 24-hour access to care. And I know we have it in patches, but we don't have it consistently over the area. So I think that's really important. And the process of respect, really, just to reiterate what Sarah said, how important it is to start that process. It's not an end-of-life document per se, but it is a document for documenting advanced wishes, and as soon as we can do that with people, the better, really. So yeah.
Okay, that's useful, and it's interesting, the 24-hour access. It probably did, but maybe people just didn't mention it.
Yeah.
Okay. And Sue, did you want to add anything?
Yeah. Thank you, Frances. Can you hear me okay?
Yes, I can. Yes.
Yeah, lovely. I mean, I think first of all, just thank you for the invitation. Sure, like Lisa, it's just been an absolute privilege to be here today, and a privilege to hear people sharing both professional and very personal situations and circumstances. I think I'm very happy for my contact details to be shared if anybody wants to find out more about what we offer this side of the county. And I think just some reassurance that we've heard quite a lot about what isn't happening, or if it is happening, it's not necessarily happening terribly well. But I think lots of reassurance that certainly in our organisation, we're working very hard to work with not just district nurses, community nurses, other services within the healthcare trust, but also forming relationships and pathways with other organisations. So we work very closely with St Wilfrid's Hospice in Eastbourne and St Michael's Hospice in Hastings and St Leonard's. We work very closely with care agencies. So there's a lot of joined up working going on. There's still lots more to be done, huge amounts to be done. But I think, you know, it's on everybody's agenda, and everybody's working very hard to try and improve things and make things, you know, better. But just, yeah, thank you again for today. It's been a lovely experience and a real privilege.
Okay, thank you. I mean, I think that's what our experience was, that somewhere the service is available, but it might not be available when you need it. So I think I think what we'd like to see is to be assured that that service is going to be there when you need it, because one never knows when you're going to die. Now I've got a couple of hands going up, and what I was going to suggest is that those people who were the original speakers, that's do stay with us, Sue and Lisa, but I was going to suggest that Christine, Marion and Lee rejoin us, and then we can take a few questions. We probably haven't got too much time, but are you able to get back in, you three?
I'm here.
And Sarah as well. So it's not just me. Okay. And if there are some questions, then I'll try and take them. Just to, as I say, just a few. And I seem to have, Marion seems to want to ask herself a question, and I've got I've got Noel Sweeney. So can we take Marion first? Did you want to raise something?
Yeah, I do want to raise something. There's something that's been sitting a bit uneasy with me, and that it feels that there's a mismatch between some of the beautiful things that we've been hearing around legacy plans and having music and the deaths that I unfortunately see in my practice, where people often die alone in care homes, or there's inadequate planning or no planning and delays in out of hours treatment. And it seems that there's a big variability. If you're able to advocate for yourself, or you have family to advocate for you, you know, if you have the resources and the skills to put together a comprehensive advanced care plan, to get onto the doula website, you have a lot more opportunity to have the death that you want. However, some of the most vulnerable and deprived in our society, who don't have people to advocate for them, have a very different experience. And I'm left feeling quite sad. I'm left feeling quite sad about that. And I think I see a skewed population in my practice. But while it's beautiful and touching to hear about all the other things that we've been talking about, I just wanted to raise that as something that I've been feeling, that mismatch, and how can we advocate for the most vulnerable and the most deprived in society, and improve the experience, improve the experience for them.
I think we touched on that in our session, and it's sort of like an inequalities in death issue, isn't it? And I think it should be, I agree with you, up the front, right up there. Now I've got a thumbs up for that one. And Noel.
To that, Frances.
Yeah, somebody. I can't see.
Di, but I can't start my video because.
Okay, Di, go ahead, and then we'll get Noel because he's had his hand up a long time. Okay, Di.
Well, the host has blocked me, so start my video. Okay. I'd obviously got my video. But one of the things that has been on my agenda when I started as a governor for Sussex Partnership was to try to find the sort of least heard voices and people who are off the radar, and that sort of you provoked that idea, Marion, when you just said, you know, what if you don't have that sort of you can't engage in that sense, that agency where you can take, you know, moves to implement a respect form or, you know, choices like that. And I wondered if there was a possibility of kind of advocates, much less than yourself, Lee, you know, just sort of more primary little advocates who just go around and make people aware in old people's homes and places like that of the fact that there are choices there to take and to offer those opportunities. You know, I mean, I'd be happy to do that because it's been on my agenda for a long time to find people who are off the radar, whether it's physical health or mental health, and it's all mental health in the end of it. But I wonder if there's any sort of gateway to discussion.
Well, I think that maybe if anybody's listening, I think maybe it does need to go up the agenda. It certainly came up a lot in our conversations, one way or the other, and people who were excluded for all sorts of different reasons. Okay, we'll note that one. Noel, you've been very patient. Are you there? I can't see you.
Yes, I am here. Yes, can you see me now?
Yes, I can. Would you like to?
Oh, wonderful. I want to kind of make a statement rather than raise a question in terms of what we do and how our services and that of other care providers, our services are commissioned. I would just ask the clinical commissioning group to really not lose sight of the fact that it's not a dashing in and dashing out service for someone who's at the end of their life. It needs to be commissioned in a much more dignified way. We are asked now, we have a number of people that we're providing a service to, and one particular lady who lives alone. The minimum visit that was commissioned for her is 30 minutes, right? And the poor lady hasn't long left to live, and you know, she lives alone. Her son is a long way away, so we're going in for this visit. These 2 visits a day. We've increased it ourselves at our own cost because we don't want her to be alone for very long periods of time. And this is just one example of many poorly commissioned and assessed services for people receiving end-of-life support. And you touched on it very nicely about the least heard voices. Okay, this really is one of those people, the least heard. Okay, she's made her wishes known. We know what her wishes are. Everyone's respecting those wishes, but we're providing her the minimum of care and support her. And we just need to exercise caution when such services are assessed and commissioned going forward.
Okay, well, I hope that's been heard, because it is, we've concentrated a lot on people being able to think in advance and express their wishes. But if the actual services are not there, they can wish all they want, can't they? So I think there is a resource issue, which we found in our report as well. Bobby, you wanted to say something.
Yeah, sorry, I've got to start my video. Oh, I can't start my video. Never mind. I suppose I just want to come back to Marion's point, which I couldn't agree more with. However, I think, you know, we spoke to the people in the room about what mattered to them. And if we spoke to the people who are very rarely asked and are often not heard, we would probably find that very similar things mattered to them as well. And I think the problem is that we don't ask, or we get this strange idea of hard to reach groups, and we just sit with it rather than persevering and making sure that people's voices can be heard. But I think this personalized thing is important, but also the very basics were so commonly held across the group: dignity, symptom control, compassion. We should almost assume that any service has got those things in it, and then we go and talk to individuals in all areas of society as best we can about what would make it better for them. So I think although we're a very privileged group to some extent, sometimes we have to get the conversation going in this group and then make the commitments to carry that conversation out into a wider environment. And on Noel's point, I think the other thing one always has to be careful of in terms of advanced planning is that ultimately at the end of your life, if you lose the ability to make choices for yourself, medical professionals under law have to make decisions about what is in your best interest. And whilst you can say things that you might not wish to be done to you, or and a treatment refusal carries through to the end of your life, there might at some point be a decision that has to be made about what's in your best interest. And families are protected sometimes from making those decisions because they feel so momentous. So, you know, should we withdraw treatment? Should we withhold treatment? Should we carry on? It's so difficult for families to take that responsibility that doctors are really invited to keep hold of it. But if people can advocate on your behalf at that point, you get this amazing sort of coming together of what the doctors know they can and can't do, and what the family can represent of what you want to do. If you've never what you want done, and what you end up with hopefully is a rich sense of the decision that will best serve somebody's interests. And I think that's why it's so important to have conversations and not just think it in your head, share it, because whether formally or otherwise, someone might have to advocate for you at some point, because legally a doctor can't just do what you said. They've got to also think, is what you said still in your best interest? So sorry, that's very rambling, but I just think it's important for people to understand.
I don't think it was rambling, Bobby. I think it illustrated, I think, quite well the complexity of these conversations and decisions and wishes, etc. They're not binary or anything like that. They're, you know, and they can change over time, and they can change quite quickly depending on your condition. So I think that's why it's also tricky. At the very last minute, things can change very differently, and people can feel very different. So I think that was a very good summary, I think, of the complexities. So thank you. Does anybody else want to raise anything or join in on the discussion? You've all gone very quiet. There's lots of questions in the chat or comments in the chat, and one of the things that I think that is coming over, that people want a lot more information about respect, just about you know, some of the details about, you know, exactly what it is, its legitimacy. I'm looking at some of these things here, you know, about a bit more information. It seems to me that I mean, Sarah said there was a big push to roll out, and I'm sure those people who are in the end of life care sphere are doing this, but it sounds like there's a lot of interest in finding out a little bit more about the nitty-gritty around respect. But
I think what I can certainly will commit to do is to make sure that, obviously I don't have access to your mailing list, but make sure that when those resources are available, that they're freely, the links are available to go on your Health Watch site, if that would be helpful. But also we could send the links out to everybody who's on the call today as well. I mean, the intention is to have quite a wide sort of media launch as well, so it could be that it will come through on in various different ways, but that, you know, you can never, I think receiving it twice is better than not at all, isn't it?
Yeah.
But,
no, that's very helpful, and we will be sending out links to this recording, and we'll be going through and having a look and see what people are asking for. So to the people who've attended this this group, so I think that will be very helpful, because it seems to me that there are quite a lot of questions. I mean, I personally would like to also reiterate that or try and emphasize that respect is just a documenting where things are recorded, and that's really important when people are not able to communicate or not at their best, or not everybody knows exactly what people want. But the big job goes on before that, doesn't it, really, thinking about what it is that you would really, what would be your preference, at the end of your life. So there's still a lot of work before that to have a conversation. Okay,
it's very much the process, Fran. You're absolutely right. It's
not just the product; it's the process.
No. Can I just say a quick thing about respect that I think came up, Fran? Respect is just one form of advanced care plan. I think Sue mentioned in the chat that there are others. I mean, respect just really relates to an emergency situation. It can be quite a medical form, although we should not use medical jargon. But there are lots of other different forms of advanced care plan. But this is a good way to roll it out, because before this, really, a do not resuscitate form was your main thing that the medical profession used. And of course, that's not an advanced care plan. That's extremely limited. And also to say it's not legally binding, the respect. If you want it to be legally binding, then you need to have an advance decision to refuse treatment. I think that's right, Bobby, isn't it? Yeah.
And it has to be very specific as well.
Yeah.
Okay, so again, more complexity, and I think you're quite right. The if you go to Care and Compassion in Dying, I think it is website, the sorts of things that people were talking about today, that they'd like keep remembering the glass of champagne, which sounds really nice, to be having a glass of champagne at your end, or whatever it is that's important to you. Most people say having people they want around them, the right people around them, and the right care and support, and as you say, pain control if necessary. But that's something that can be indicated elsewhere. But I think you're right, it's not legally binding, it's a wish. It's something that people can refer to. So the other areas, the questions that are coming up are around the doula or the companion, wanting to know more about it, and I think maybe we can do that, can't we, Lee? We can actually pull together some information about what the doula does, and people were very interested in it, and some people were even interested in being one. So I think that's another area that we can pull together some information. Now, if there are no more sort of questions and comments, speak now.
A cheeky question, Fran. Can I just ask a cheeky question?
Oh, go ahead. The cheeky question is often the important question. Go ahead.
I'm going to ask it of Sarah, because I feel being in a group, having got to know each other in the group, I can put her on the spot. If one of the things that came out of this meeting was the fact that the sort of work that a doula or end of life companion can offer is very appealing to people or reassuring, do you think in future there is a way in which that could become part of what is offered through the National Health Service or social care, or will it, as to extend Marion's worries, be something that relies on the generosity of doulas in terms of cross-subsidising their activities, charging minimal amounts to those that can afford it and then nothing to those who can't?
Thanks, Bobby, not putting me on the spot or anything. I think the from my personal viewpoint and belief perspective, having worked in end of life care as a clinician as well as now commissioning services, I see it very much as a holistic approach. I think there are lots of opportunities, and I was thinking when Lee was talking about that nobody ever dying alone, I know previously we'd worked with Worthing and St Richard's Hospital with the chaplains there around, they have a group of volunteers who provide just that sort of service. So I think these sorts of events really provide, I find, most valuable because they connect me with things that are going on. And so it is about always trying to build on those experiences and what's out there and what's important and how we can make those connections and how those really work with a pathway that you're developing. And I can really see links into those sorts of works. I can really see links into the compassionate communities that are beginning to evolve and the work that we're doing with our public health colleagues as well. So I think it's just about making sure you don't lose sight of that, and you always keep that in the frame when you're thinking about, yes, we do have a statutory responsibility for commissioning certain things, but I think the richness is how you bring the community around those services. So you're the sum of the parts and not just the binary. We've talked quite a lot about binary things, haven't we, today? It's not just a one thing or another. It is the sum of the parts, isn't it? And Lisa will know from having worked with me for a long period of time that I'm always talking with my hands, and it's always about how we can work together. And I think it's really important to keep that ethos going and learn from those real lived experiences and make sure that you don't, that those don't get left behind in those discussions. And I think that there's that sort of side around, I say inequalities in the widest sense. I don't want to again reduce it to just a title. I think that those aspects really need to be front and central in that sort of personalised approach to how we shape services for the future. So thank you for your question.
Okay, I'm going to wind up now because people are going and they expect to be going soon. I'm not going to attempt to sum up on everything that people said. It sounds to me though that from what people have come out with in the workshops, we've got a sort of some benchmarks for what good care looks like, end of life care looks like, and I think that we need to pull that together. So this is what a good death looks like, type of piece of work. We've talked about respect being really important. It does seem to be the vehicle that's on the road at the moment, so let's use it and make it the best we can. I'd just like to thank everybody for giving their time, all of you who are the audience, if you like. There's lots of stuff coming in the chat with resources. We'll push them out, let you know what people are saying is available, try and make it in some coherent way. I'd like particularly to thank Marion, Lee, Christine, Sarah, Bobby. I'm going to miss somebody out here. Michelle, who's in the Health Watch office, and Rebecca and Cheryl, who's in the Health Watch office in West Sussex, all of whom we couldn't have managed without them on the technical side and the organisational side. So thank you very much. And I just hope this is the start of a discussion, a start of some change, a start of some improvement, a start of more networking, you know, so that there'll be better end of life care for people in this area. So thank you very much, everybody, for coming. Thank you.
Thank you.
Bye-bye.
Bye.
Thanks very much. That was great.
Yeah, thank you very much. Great to see everybody.
Thank you.
Thank you very much. Yep, very good.
Thank you very much indeed. It was a great webinar. Thank you.
Thank you very much.